Hello, I'm Mark Jones. I'll be talking today about treating anxiety and PTSD with neurofeedback. I am the founder of the Well Mind Center in San Antonio. We have counseling and neurofeedback practice, and I'm an adjunct professor and director of the neurofeedback program at the University of Texas in San Antonio, and that's under the auspices of the counseling department. I have my email addresses listed if you want to follow up with me about the presentation. Feel free to drop me a line. Okay, so in talking about the topics, and I'm gonna talk about anxiety first, and then we will talk about PTSD. But I'll be breaking it down in terms of symptoms and prevalence, the neurophysiology of the various syndromes. In other words, what's going on in the brain, related evidence-based treatments as applicable, be talking about QEEG or ERP markers, and sharing some of the research, either that which I've published or others, and some of the presuppositions that I have in mind as I approach the topic. I'm interested in evidence-based approaches and using EEG-based assessments. In other words, it's not just symptom-based assessment. I'm also interested in what is cost-effective for clients or patients, as well as for practitioners. One of the this has been very much on my mind as I have developed a program at UTSA, knowing that counseling students don't always have a big chunk of change in the bank. And what is an approach that they can afford to implement in their practices, and then thinking in terms of what is more affordable, cost-effective for clients, wanting to make neurofeedback as accessible as possible. And so that includes affordability, and also what is user-friendly, what is it that students and clinicians can learn to use and implement fairly quickly. All right, let's talk about anxiety disorders, looking at the diagnostic categories and symptoms. Normally, when I lecture on this, I break each of these different types of anxiety disorder diagnoses down into their separate symptom criteria, but let's just suffice it to say that there are a number of types of anxiety disorders. And this is one of the reasons, and when I'm talking about anxiety, I usually will just say anxiety-related disorders. There's generalized anxiety disorder, which people commonly associate with just anxiety that is experienced in a wide variety of contexts. Panic disorder is like a more severe form of anxiety that can be quite disabling. Phobia-related anxiety disorders are specific to certain objects or experiences. Social anxiety is a class of anxiety disorder experienced in social context or fear of contexts that are social in nature, and which in my mind kind of bleeds over into agoraphobia. The agora was the meeting place, and when the Greeks talked about the agora, that would be the the folks the place where you got together. So if you have a fear of the agora, you have a fear of places outside your home, maybe where people would be congregated, such as a grocery store. Separation anxiety, we often think of that in terms of children who are afraid of being separated from their parents, but it can be the other way around, actually. And even as children grow into adulthood, sometimes their parents can be overly fearful of their safety. But that's just a real quick overview of different types of anxiety disorder. And let me talk also about, and this is also in general, about risk factors for anxiety. It has been found that there are certain temperamental traits or personality traits that predispose people to have an anxiety disorder, such as shyness or behavioral inhibition in childhood. Also, exposure to stressful and negative life or environmental events in early childhood or even in adulthood can leave us prone to an onset of an anxiety disorder. And bear in mind that a disorder is something that interferes with social, occupational kinds of functioning, academic functioning in a number of contexts. A history of anxiety or other mental illnesses in biological relatives can be a risk factor. And some health conditions, such as thyroid problems, heart arrhythmias, excess caffeine, or even normal amounts of caffeine or other substances or medications, can produce or aggravate anxiety symptoms. And for this reason, as is often the case with mental health issues, it's important to rule out any physiological causes of the symptom that we're trying to help people overcome. All right, let's talk about prevalence and severity, and I'm a bit dependent on the National Institutes of Health and the CDC for some of these statistics, and these aren't necessarily as up to date as we would like, but and there have been some changes in these figures due to the pandemic, where anxiety was more severe and prevalent. But it's estimated that 19% of adults in this country have had or met the criteria for an anxiety disorder in the past year. And the prevalence of that tends to be higher for females than males. And bear in mind, we don't have good statistics that reflect transgender or other gender identity factors. A lot of times this is kind of limited to male and female. And the statistics, maybe that will change as time goes on. And also, at almost a third of U.S. adults experience or meet the criteria for an anxiety disorder at some points in their lives. So we have the prevalence over the past year and then a lifetime prevalence. And as I mentioned, these statistics can be somewhat dated. If we break these down, we've already noted that anxiety tends to be more prevalent for females than males. And if we look at it in terms of age groups, the prevalence tends to go down with age in terms of adults. So when you get to be my age, you don't tend to be as anxious about things, I guess. If we looked at it in terms of severity, the largest category would be mild severity, and then next moderate, but still almost a fourth of those who have an anxiety disorder would be in the serious category of severity. Looking at adolescents, age 13 to 18, the prevalence is higher, 32%. And along with anxiety, it's estimated that 8% have a severe impairment of it. And these were older criteria that were used to determine the impairment. There was a day when we looked at the global assessment of functioning kind of thing that's been discontinued in the newer DSMs. And as in adults, anxiety tends to be more prevalent among females than males. And it is similar across subcategories of age groups. So here we have a 39% prevalence of anxiety, 8% severe, more prevalent among females, and the prevalence is fairly even across age groups. This slide is documenting what I had mentioned earlier about an increase in anxiety related issues due to the pandemic. It increased significantly, and then we noticed a decline, a marked decline in symptomatology as the pandemic kind of wore on a bit. And it seems that these issues affected all demographic characteristics of people in the population. And not only anxiety, but depression, the prevalence of depression increased significantly during the pandemic. Let's talk about what's going on in the brain in terms of anxiety. This is a diagram that's put together with data from Michael Linda Thompson's book, the Neurofeedback book, looking at the affective network in terms of where you're most likely to measure it. This is the 10-10 system of electrode placement. But you can see in the temporal and areas and the frontal to midline, okay? So these are placement locations that are most likely to measure activity in what we call the affective network. And looking at the connections, and we're looking at the limbic system and these fascicula that are tracks of axonal connections. There are some notable tracks that are involved in the affective network, and one that I'm particularly interested in is the uncinate fasciculus, which connects the prefrontal cortex with the limbic system. And this circuit functions much like a spillway on a dam, and so there is an activation of the limbic system from the prefrontal cortex, for one thing, and there's a modulation process that goes on here. One theory is that this modulating process has been weakened or is dysfunctional in some fashion, and we might see that with issues around the anterior limb of the cingulate gyrus, as well as the medial prefrontal cortex areas. So, and then also, when we talk about the anterior cingulate, it's sitting right in this area, the genual area of the anterior cingulate that comes on around below this genus of the corpus callosum. And so this ventral area functions a great deal in affective functions, but here is a regulating kind of gateway, if you will. The fear network also identified in similar fashion, but here we see the temporal and the midline areas that the Thompsons were mapping as most measurable from the scalp, okay? And then we have the limbic areas that are involved in the fear network. Here from another angle, I love this, the 3 dimensions kind of this map. This would be the frontal lobe, the right frontal lobe, can get you oriented. Imagine a brain that's kind of facing you a bit off to the side, and you've removed the left quadrant, exposing the medial aspect of the right hemisphere. So we have the dorsal anterior cingulate coming around the ventral medial prefrontal cortex here, the insular cortex being identified. If you could kind of pull that temporal lobe down, it would expose the insular cortex. The amygdala and the hippocampus are involved in this fear network. So here's another way of depicting the location of these areas. The dorsal anterior cingulate coming around the corpus callosum, the rostral ear anterior cingulate, and then the insular cortex. This particular diagram by Kahn and others really shows a progression of activity in networks associated with fear. And I broke this down a bit. Imagine walking in the backyard, and if yours looks like mine, the grass may grow up. You see a long tubular thing in the ear. Your brain might go, "Oh no, there's a snake," and you get this immediate reaction that involves the ventrolateral prefrontal cortex and insula and related issues. So there's a network of activation, and then you realize, oh, it's a garden hose. Okay. And so then there's another network function that begins to restore some homeostasis and brings you back to kind of a more chilled out baseline. Hopefully we stay in this state most of the time. This is another great diagram, actually from an article on the neurobiology of postpartum anxiety and depression. But what they're showing here are the areas that are involved in depression and anxiety. And bear in mind, there's a 60% comorbidity of depression and anxiety. If you have one, a 60% chance you're going to have the other, and this will explain that to a certain degree. So look at the color scheme here. Blue related to depressive disorder. Darker shades of blue would be higher activation. Lighter shades of blue would be less activation. And with anxiety, the yellow color, the darker yellow would be related to anxiety. So here the insular cortex you see is related to depression and anxiety in the higher activation levels. The orbital frontal cortex with less activation related to depression. And here we see it again. This is more of the medial view from inside. And then we have this frontal cortex area associated with anxiety and a less activated area. And then we see another overlap of the anterior cingulate and the dorsolateral prefrontal cortex involved both in anxiety, depression, the striatum primarily with depression. And then there's that little almond-shaped item, the amygdala, that's highly involved in both depression and anxiety. So you begin to see why there's such a crossover between anxiety and depression symptoms. So what about treatments for anxiety? And these would be listed as evidence-based according to extant research, cognitive behavioral therapy, medication using anxiety or anti-anxiolytics, benzodiazepine, buspirone have been widely used. Fortunately, there's an emphasis on reducing the prevalence of prescribing benzodiazepine class drugs such as Xanax, Ativan, what was one of the first ones? Anyway, and these would be indicated for short-term use. Long-term use has been correlated with early onset and severity of dementia and things of that nature. And so there's been a shift toward trying to use beta blockers, which are going to slow the heart rate, and it can be effective for people who tend to be kind of easily aroused, panicky. They can be short-acting and this kind of thing. Also, antidepressants, but with the caveat that they may increase suicidality, at least temporarily upon initial use, SSRIs, tricyclics, and MAOIs. And these are often used and other related drugs for anxiety, right? Support groups can be efficacious, stress management techniques. So this is one of those things where the more tools you have in your tool belt, the better. And this is a little breakdown of the benzos. And when we look at the effect of these drugs on the EEG, it's quite significant. We'll look at what some of this referred to as the benzo buzz in the EEG. It really kicks up beta activity, and this can last for weeks, even after discontinuing the drugs. Also decreases alpha and the general voltage of the EEG, and sometimes you can get a slight increase of beta activity and a reduction in paroxysms, which are temporal bursts of activity, because they raise the seizure threshold. Okay, so they have an anticonvulsant characteristic. Here's what I'm talking about with the benzo buzz, and this isn't all muscle or EMG. There's just, and when you first look at it, you go, "Oh my gosh, look at all the EMG!" But this is by and large sinusoidal activity, unlike muscle, which is biphasic. And so, if you look at this in terms of spectra, you would see a ton of beta and high beta activity from on the benzos. People who are taking these drugs on a routine basis, you can't just say, I'm not going to take it so I can go get an EEG. But if they are on these medications, it, in my opinion, renders the EEG virtually useless because the drug has co-opted the activity of the EEG. I'm not sure what this increase of activity represents. My hunch is that it is boosting the GABA inhibitory networks. These drugs act to raise that spillway I was talking about earlier. And so there's an activation, although it feels quite calming, but you're activating an inhibitory network. So what do we do with neurofeedback? And everybody has their own opinions, but this is mine. I want to train to the EEG markers. As Jonathan Walker in Dallas says, a neurologist, nobody needs too much beta or high beta. So wherever it is, train it down, right? And if we're looking at where this kind of circuitry shows up, that midline excess beta, high beta activity would be something to look for. Frontal hypercoherent, that should be hypercoherent. Alpha can be an indicator of a breakdown. This is one theory of a breakdown of that modulating circuit. Attenuated posterior alpha, and what you sometimes see with the low amplitude fast in the phenotype. And this can have a genetic component. And what you see is, and we'll look at it, is a low voltage, a low amplitude of the EEG, but it's fast. In other words, you're not seeing a dominance of delta theta activity. That's not a good thing to have a low amplitude, slow EEG. And so this is often treated with an alpha up protocol. These folks have too little alpha and sometimes no identifiable or measurable alpha. And so training up alpha in the back of the head, eyes closed, is kind of a convention. Training to the ICA or Loretta markers, and here we're looking for medial prefrontal cortex and anterior cingulate dysregulation. Too much activity, too little activity might be an indicator of some dysregulation there. And there are EEG markers that aren't always visible on a QEEG, such as beta or high beta spindles, little burst of fast activity, which may not occur enough to show up in the average data used for QEEG metrics. And then also there are ERP markers, event-related potentials. So it's a challenge to go from ERP findings to a neurofeedback protocol because you're measuring and treating a very different mechanism. But we'll look at that. So QEEG guided neurofeedback, where you're doing a quantitative analysis of spectra, topography, coherence, ICA Loretta, on, and you're basing the neurofeedback protocols on these findings, such as amplitude training or up-training of selected frequency bands. And in this regard, I've been largely influenced by these studies. Here's one way to look at anxiety subtypes in the brain map QEEG world, low amplitude fast, where you would see the Z-scores, the colors are tending toward the blue or below average end of the spectrum. Maybe not statistically significant, but I see a lot of these spectra coming in about one standard deviation below across the spectrum. So one way to define a low amplitude fast in the phenotype. Throttle hypercoherent alpha, which is going to show up in the front of the head, low alpha in the back of the head, and then high beta, which often occurs centrally or frontally. Here's an example of a low amplitude fast EEG. If you look at enough of these, it kind of just appears that way to your eye, and not a lot of rhythmicity in the EEG. And then when you do the numbers, you can see that it's pretty much below the mean across the board. And here's pre and post spectra on an individual where we did the alpha up training. This person happened to have a fast alpha, and the purple is the post Z-score data, and you see we were able to boost that alpha up quite a bit, and why the delta came up along with it, I'm not exactly sure. But then we look at it across the spectrum and absolute power. There again, you see just the amplitude of the EEG came up. Alpha is responsible for much of the amplitude or voltage of the EEG anyway. Here it is on the Z-score spectra along with the absolute. And pick out an alpha peak in there, challenge it. Sometimes you not only can't see it, but it's not even measurable. And here is the topography of an individual with this low amplitude fast, but also a midline high beta. And here, this is absolute power, but you see against the baseline, we have a little bit of an increase in in the frontal midline high beta. In the relative power, this becomes much more apparent. You have to be careful with relative power, but here it helps us to see. And one of the values of relative power is when you have low voltage EEGs, it can kind of help you see the differences and accentuate these differences. So here we have low alpha, and we have elevated beta in the central and frontal areas. With NeuroGuide, you often get a washout in the 1 hertz bin due to the calibration of the EEG with these older amps that were used for that database. So here is a low amplitude fast with beta spindles. I'm going to have to kick it up here and move on. And you're going, where's the beta spindles? Well, there's a little, I call them low amplitude beta spindles. And here's the spectra where you see this increase in beta activity and high beta activity here, about 29 hertz is where it's really showing up. And in this case, we see the location of the spindles in the parietal areas. They're more commonly found in the frontal, but here in the parietal, and often this is associated with some kind of sensory hypersensitivity. Here's the relative power where it's quite obvious. A fast alpha, this is a 12 hertz alpha, and can with a base band of 10 to 14, right, hertz. And so this can be a finding with individuals who tend to be a bit nervous. I'm not for trying to slow down people's alpha. Sometimes you can help them get a little more variability with their alpha, but they may tend to be a nervous sort of person. Here's the spectra. You see it's coming in right at 12, 12.5 on that peak. And here is a great example of a harmonic of that alpha. We're at 12.5 hertz or so here, and 12.5. We're getting a peak around 24.5 hertz. That's a harmonic, and you can see there's not a whole lot of 25 hertz activity visible, and you have to be careful. This is a quirk of the Fourier transform algorithm used to measure activity that is not perfectly sinusoidal because it's a biological mechanism. So here is the z-scores on this fast alpha. And, are they really that high in amplitude, or is it the database is not, doesn't contain a lot of folks at 12.5 hertz alpha, so it really washes out the amplitude measure. So you have to be careful. This is not necessarily a high amplitude alpha in itself, but it's high compared to what people might normally have. Loretta ICA markers. Here is a marker for the anterior cingulate dysregulation. We have a pattern of activity in the theta range here, and this is an individual with anxiety-related symptoms. Now, event-related potentials are a way of measuring how the brain responds to a stimulus, and you have to average hundreds of these together to get this picture of what's going on. Here is a half a second, right, of markers of characteristics of the brain, sensory perception, and then higher order processing that's taking place. And when you have this measured at all of the electrode sites, you can get a very interesting picture of what's going on in the brain. Now, how you go from this to neurofeedback, you can't hardly do neurofeedback on a process that requires you to average hundreds of trials to do that, although there are some folks showing some possibility of measuring these more in real time. So the way you would with the WinEEG system, it's a go, no go. In this particular paradigm of the visual continuous performance. So if you see an animal followed by an animal, press the button. If you see an animal that's not followed by an animal, don't press the button. If there's a plant, ignore it. If there's a plant or a human, ignore it. If it's a human, you get a beat. And so these have been normed. There's databases that will show you ERPs against a normative database, and it can be incredibly helpful. Here is an ERP marker commonly associated with anxiety, and it's in the occipitals. There's a hyper arousal function going on that's related to the affective system. Yuri Kropotov, in this case, has some interesting suggestions for neurofeedback in these situations. Wow, this looks like a research project in the making, doesn't it? Okay, and I won't go into this, but I like to use what I call imagine desensitization using the old behavioral technique, along with neurofeedback. Laura Jackson Cook did use this technique in her dissertation recently with good results for folks who were anxious and burned out. We've been publishing data on neurofeedback for anxiety for some time. It's kind of an ongoing pilot at the university. Heather Hitzman, my GA at the time, helped me compile the data, and we published that in 2018. So in that study, it's retrospective. We don't have a control group. We had 40 subjects, we did pre and post cues, pre and post Zoom anxiety, and we used the Achenbach system assessment. And and it's student counselors doing the neurofeedback for what that's worth, using one-channel neurofeedback. And as a group, we had a decrease in the Zoom anxiety scale, a decrease in the Achenbach anxious depression scale, a decrease in the Achenbach anxiety problem scale, and a decrease in the Achenbach total problems scale. And all scales were brought into the non-clinical range, the normal range, and we achieved that at an average number of sessions of 12. Here are the statistics showing the p-values and the effect sizes, so on and so forth. You can look that up. Going on to PTSD, now this is going to be an arousal issue as well. Just kind of giving you a little preview. Looking at the time here, I'm not going to belabor the symptomatology. I think you can look that up. As I mentioned, syndromes of over-arousal and behavioral concomitants. So what do we mean by PTSD? What do we mean by trauma? Violent personal assaults, natural human-caused disasters, accidents, combat, other forms of violence. These are life-changing traumatic events that leave a footprint in a person's emotional state, and this can be seen in brain activity. The prevalence rate, almost 4% of the population, more prevalent among females, and less prevalent in the elder years. The severity is pretty much equal across the board, with adolescents less prevalent in the younger years. I guess the longer you're on the planet, the more likely you are to get traumatic events. Studies are looking at different types of trauma, sexual relationship violence, interpersonal network, which can include the unexpected death of a loved one. If you've lost a loved one, you know how traumatic that can be in and of itself. Interpersonal violence, exposure to organized violence. Lord, if that's not in the headlines these days, in our war-torn world. Just one note, and I'll leave it there. What are we going to do to reach out to millions of people who are being terribly traumatized? We can send money, we can send supplies, but what are we going to do? And reaching out for mental health services. Just leave it at that. Okay, kind of plotting the epidemiological picture of PTSD, you see a lot of the traumas coming from interpersonal networks and sexual relationship violence. So, one of my colleagues at the university and I were looking at applying for an NIH grant to treat folks with PTSD with neurofeedback. I don't know what we were thinking. Bessel van der Kolk couldn't get a NIH grant. Why did we think we were going to? But I got to looking at brain scan data, fMRI and other brain scan data of people with PTSD. As you can imagine, from one study to another, it's all over the map, but I was looking for what are the common components. that you see. And at that time, I was noting three. One is an underarousal in the medial prefrontal cortex. So part of that modulating area and network I was pointing out with anxiety, over arousal in the right amygdala. Okay. PTSD is in many ways a right hemisphere issue. It could be because of the nonverbal, visceral element of it. And then underarousal in the right hippocampus. Some studies have shown a reduced volume or mass of the hippocampus with folks with PTSD. What does that say about memory? So underarousal, overarousal, underarousal. So looking at the medial prefrontal cortex, underaroused, not doing its job. The amygdala doing its job too well. Okay. And then the hippocampus, which is part of this limbic area, is also affected. And so the brain is locked in to this pattern, and the symptoms persist. So treatments, some that have been widely used and studied, exposure therapy, cognitive behavioral work, EMDR shows a lot of promise and has helped a lot of folks, even in my practice. Medications that are often used, SSRIs, benzodiazepines. Neurofeedback is making more of a footprint. Going back to Eugene Peniston, who was a VA psychologist, used what's now called the Peniston protocol, skin temperature biofeedback to lower sympathetic nervous system arousal, training up alpha. And he would also train up theta at O1, which is the left occipital area. And then what he called their psychotherapy, kind of an emotional support kind of presence, as the folks he was treating, Vietnam vets with PTSD and treatment-resistant alcoholism. Seaburn Fisher, a beautiful book on developmental trauma. You can imagine that as a combination of PTSD and reactive attachment disorder. She outlines a very well thought out and practiced, evidence-based practice of neurofeedback in her book. And then Thomas Ross, and others who have researched the Alpha Down protocol. Here is the one of the original studies with Peniston in 1991, and improvements on the MMPI with this neurofeedback training pre and post, much more effective than treatment as usual. Okay, so just looking at PubMed, a lot of studies are showing up. This is Van der Kolk study showing efficacy of a neurofeedback program protocol that's right side T4 minus P4 alpha kind of thing. And it was adjusted based on its effect during the treatment, depending on the effect it was having on the clients. Highly effective, huge effect size with this group. Now, he had a wait list control, so not considered of the highest category of efficacy, but certainly made a point. We've been trying, or we did for a while, trying to replicate that study at the university, and we had pretty impressive results as well. Significant reduction in the trauma Davidson scores and the Isaac scores. These are highly significant. So, and I have some slides you can look at, which basically are Van der Kolk's application for having developmental trauma, which is the result of early childhood trauma and or neglect and the effect it has on development. He was applying to get that included in the DSM. Apparently it didn't happen. But I also have some information here further about efficacy-based treatments. A great website here. This list goes on and on of studies that have shown different types of treatment. Here are two of my heroes in this field, Sieber and Fisher, Bessel van der Kolk, who've collaborated in large measure in this, their respective books. I wrote a review of Siebern's book, and I use the word beautiful. It's beautifully written. What a clinician. And so there's some studies on the alpha down, which is kind of counterintuitive, but training down posterior alpha, eyes open. Now, these are studies showing changes in the brain, the limbic system, calming down after one session, after around 20 sessions or more, and they're seeing changes measured by fMRI scans. So not just subjective symptom, but symptom improvement as well as noticeable changes in the brain. And here is the protocol that was used and the results. So that is something I really want to point your attention to as we think about treating PTSD, showing a lot of promise. So, and some other alpha down studies that Ross and Ruth Lanius participated in. So, worth taking a look. Okay, I'm going to open this up and ask Eunice if we have any questions.
Hello. We did get one comment from Julie, who mentioned under arousal in medial prefrontal cortex suggests maybe home HEG BFB. For example, the Mendy training might help.
Yeah, you could call that neurofeedback. It's hemoencephalography, which can be a way to activate the cortex via measuring oxygenation and blood volume. And the Mendy is a neat little device. And there's also the Tumen design, the near-infrared headband that's been around for some time. So
Yes, and she wanted to specify in the use of training for lowering symptoms of PTSD.
worth a shot. Anything else, Eunice?
Joaquin also had a question of when you were talking about under arousal and medial prefrontal cortex, if you meant the left or right.
Bilateral. I should have specified that was bilateral, both sides.
He also asks, is there any sign of dissociation in QEEG?
You know, that's a good question. I've actually had the fortune or misfortune of having folks who reported dissociating during an EEG. And in those cases, there was predominance of frontal theta. And you would imagine it was drowsiness, but they were quite clear that they were not drowsy. But these are individuals with PTSD, and they were quite aware of when they had just been dissociating. So that maybe that's what. I also had some clients panic attacks, and believe it or not, there was a predominance of theta activity there as well. Theta has been identified as the frequency of the limbic system, so maybe there's something to that. Yeah, sorry for the fire hose effect of my presentation. I guess I can't help it. I'm a professor and wanted to get as much information out. And there is a PDF of these slides available for you, where you can go back and look more specifically.
If you guys do get any questions, you can always email me or Dr. Jones. I put his emails up in the chat. I think I can copy them really fast. There you go. He beat me to it. You can always reach out. Feel free to reach out. And if you have any other questions, you can always email education@inmindout.com. And thank you everyone for your time. And thank you specifically, Dr. Jones, for all of your valuable time and all of the information you've provided today.
Thank you. Welcome.
Yes.
You're welcome.
Thank you. All right, everybody, have a good evening.
Bye-bye.